Welcome to our online information session. We're sorry that we can't be with you in person, but we've put together a series of videos to better help prepare you for surgery. This month's videos will include a presentation from John Keeley, Clinical Education Specialist with the Sleep Center. Dr. Derek Stephenson will present an introduction to bariatric surgery, and Dr. Ahmed Attia will answer questions from Susan Shropshire, our clinical coordinator. We hope that you enjoy the videos, and remember, at the end of the videos, please complete the quiz in order to gain your certificate of completion. We hope to see you in person soon. Okay, welcome to our online information session for Inspira's bariatric surgery program. Tonight's speaker will be Dr. Derek Stephenson with an introduction to bariatric surgery. Dr. Stephenson?
Hello. So as said, I'm Dr. Stephenson. I'm one of the surgeons in our bariatric program here. I work along with Dr. Attia and the other surgeon, our assistant being Dr. Iqbal. I'm going to be giving a brief introduction to bariatric surgery, a short presentation to kind of explain a little bit of what we do, how we do it, and why we do it. So first, as kind of an introduction, just to explain a little bit about the importance of this issue, obesity is becoming a larger issue in the country and the world at large. It has a high economic cost and related to healthcare, but more important, it has a lot of high related health consequences, as obesity is one of the highest causes of preventable death, meaning people are dying from something that we could otherwise treat and manage. As a result, obesity is being termed one of the new health epidemics. And as you can see, almost a third of US adults are now considered to be obese. If you compare this to numbers saying back in the past, that number was as low as about 11%. When you consider the overall population of the country, a jump in that is a huge amount. So this is a problem that we're all facing together. So to kind of show that graphically, this shows the incidence or the amount of obesity in the population per state. And it works kind of like a stoplight. So green is a low percentage, not too bad. Yellow kind of being a little cautious, and the orangish red starting to get a little high. So as it starts in 2011, we'll start going through the years. And then 2012, 13, 14, 15, 16, then up to 2017, what you're seeing are levels of obesity, as in the kind of dark burgundy, that didn't even exist back when we started. And so as you can see, this is a growing problem. And so as we deal with it, you'll hear a lot of different terms. And one of the most common when we're dealing with things related to obesity and especially bariatric surgery is BMI, which stands for body mass index. What this is, it's a screening test, meaning it's a quick method to kind of put people into categories, and it tells us information about them. And so we use your height and your weight, and we get a number. And that number is quick and easy to use, but it correlates with something that would be more difficult to do, such as body fat measurements. So this gives an example of the BMI. So the chart below, for someone at that given height, it'll show the numbers that the range would be for a given weight. And it breaks the categories into what's essentially considered normal or healthy weight to overweight. And then once the BMI gets above 30, you get into that category of obesity. And another term you might hear is morbid obesity. And so what this technically is being 100 pounds over your ideal body weight. An ideal body weight is just a more complicated formula that they created, and they take more factors such as age, gender, height, weight, and you have to put into this big calculator and it'll give you a number, and they'll say what someone's ideal weight should be. But that's too complicated to use regularly. And so we simplified it and we use the BMI, which is much more commonly used to represent it. And so a BMI greater than 35 is considered morbid obesity. And this is important to us because it fits into the qualifications of who can get weight loss surgery. So the general initial qualifications are based on the BMI, or the body mass index. So if you have a BMI greater than 40, that in and of itself qualifies most people for weight loss surgery. If your BMI is between 35 and 40, you need a medical condition related to weight issues. If your BMI is less than 35, you generally don't qualify for a surgical procedure and have to look into other options such as diet, exercise, and medication. So what are those weight-related medical conditions? These are all things that either develop or worsen as weight increases. They include things such as high blood pressure, diabetes, high cholesterol, sleep apnea. And so the list is growing, as you can see. But the good news is these are all things that improve, or in some cases go away, as weight goes down. And so people with high blood pressure, after the surgery, their blood pressure gets better. Hopefully they can get off their blood pressure medicines. It's very good for diabetes. A lot of people who are on insulin can get off insulin, and sometimes off medications entirely. For sleep apnea, if you have a CPAP machine, over time you can wean that off and no longer need that. And even things such as cancer risk and heart disease, they're finding the risk goes down as weight decreases as well. And there are even more studies that they're doing and finding more benefits for things such as fatty liver disease. They're seeing some reversal in that and effects on the immune system. So overall, we're finding a lot of benefits to weight loss surgery. And this gets into kind of why we do this. The main reason is for health. As physicians, our goal is to treat medical problems. And so through doing these procedures, our goal is to improve or resolve all these medical conditions, stop people from getting them if they don't have them, because they would over time, hopefully get people off medications that they no longer need, and in the end, improve their lifestyle so they can live a longer, healthier life. So that gets into the procedures we do and how we do them. And so surgeries, especially surgeries in the belly in general, can be done in one of two ways, what we call laparoscopic or open surgery. So open surgery is the way things used to be done years ago for any surgery, where they make a big incision kind of down the middle of the belly, and then they go inside and do whatever they need to do. But now with laparoscopic, instead what we do is we make very small incisions, and then we inflate the inside of the belly with a gas and go inside with a camera. And we can do a lot of the same surgeries that way. And this has a lot of benefits. It allows faster healing, decreased time in the hospital, usually less pain, because most of the pain from surgery actually comes from the incisions. When you make a big, large incision, there's a lot of pain. With these very small incisions, there's not much at all. And then this allows you to get back to work faster, and there's less scarring, both on the outside, because smaller cuts heal better, but also on the inside. Because when you do surgery inside the belly, the body responds naturally by creating scar tissue. When we make an open surgery, it does a lot of scar tissue, but when we do it laparoscopic, it barely makes any, or sometimes none at all. The procedures themselves can be split into two kind of general categories, which is based on how they're performed, or more how they work. So the first would be restrictive, meaning it restricts or limits what you take in. That would be mostly the sleeve. And then there's malabsorptive, which has a restrictive component, but mostly works by changing the way your body processes or absorbs the food you eat. And that would be the gastric bypass. Now, the lap band, we kind of talk about almost more historically, but it was pretty common some years ago. As you can see in the picture there, it's essentially a small balloon, if you can imagine, wrapped around a plastic collar. And that collar we wrap around the top part of the stomach, and it's attached with a cord to a port, which we implant under the skin in the belly. And then when we are ready to adjust it, we would use a special needle to inject fluid into the balloon so it inflates and squeezes on the top part of the stomach, which, as we said, restricts how much you can take in. The problems we found with it, however, were it didn't work as well as the other procedures we do, mainly the sleeve and the bypass. Although some people had good results with it, on the whole, the weight loss was lower overall, and it was also slower. And then that adjustable part can be kind of a negative, because it means you have to come to the office, get poked with a needle so we can inflate the balloon. But if we inflate it too much, then when you go home, you try to eat and nothing goes down and you're throwing up, So we have to deflate the balloon, but then it's not squeezing or doing anything. You kind of bounce up and down so you can get a perfect level. And then over time, we found issues with it, such as it's a foreign body, the body reacts by trying to fight against it. We can develop things like hiatal hernias, the band can slip, and over time, we end up having to take a lot of them out. So the band we don't actually do anymore. But the main procedures we do are the sleeve and the bypass, with the sleeve probably being the most common at this point. So this video will kind of show a little illustration-wise, both the procedure for the sleeve and also how we do the surgery laparoscopically. So as you can see from the outside, with the laparoscopic surgery, we make very small incisions, usually 5 of them. And then these are trocars that give us access to the inside of the belly. And as I said, we inflate the inside with a gas so we can see, and we go inside with a camera and do all our work with instruments, kind of like this. So as we get to the inside, this shows kind of the normal anatomy of things the way they are now. And when you eat, food comes down the food pipe into the stomach, and the stomach's main job is to work as sort of a reservoir. And so it's almost like a balloon, so it expands as you eat more until it gets full to the point where it can't take any more. And so with the sleeve, what we do is we come in and we cut the stomach, similar to this, and that whole portion we take out and remove, leaving a small tube that looks kind of like a sleeve of an arm, which is why they call it that. And then by doing that, what we've done is remove a lot of the portion of the stomach that stretches when you eat. So now when you eat, the food comes down the normal way it does, but it takes less of it for the stomach to stretch all the way, which sends a signal to the brain to say, I'm full, and causes you to no longer feel hungry. But the food still gets absorbed and processed the way it normally was, and this overall leads to the weight loss. So the benefits of the sleeve, probably most importantly, is that it works. We see excellent results with it. Because we're really just changing the size of the stomach, there's no real dietary restrictions, which we'll get into a little with the bypass. And there's almost no nutritional deficits as well. It's a little less complicated of a procedure to perform. The only kind of real downside is it's permanent, because the part of the stomach we're taking out is being fully removed. The other procedure we perform is the gastric bypass. This is a little bit larger of a procedure. It's also done laparoscopically. So similar to the sleeve, you'll see the small incisions, usually about 6 for the bypass. Then in the same way, we use the kind of instruments in the camera on the inside to do the whole surgery. And so again, normal anatomy on the inside. But this time with the bypass, we're not actually taking anything out. We start by separating the top part of the stomach from the rest of it to make a small pouch. But then we actually come down to the intestines or the bowels and we cut them and then reroute them or move them up to that new part of the stomach, kind of like moving plumbing around. But now that other part of the stomach still stays there and makes acid and things you need. And so we reattach the bowel to itself down below so it has somewhere to go. And so now when you eat, the food comes down that new pathway, and the things you need to digest your food come down the old system on the left, but they don't meet up until they get all the way down where we attach the bowel to itself, which causes the body to not absorb as much from the food you eat, which leads to the weight loss. So benefits of the bypass, it also works. It's been around the longest of the procedures. They've been doing it since about the 60s, I believe. But it does have some downsides. The weight loss can actually be too much because we're changing the way your body's processing or absorbing the food. It doesn't absorb enough of the vitamins, especially certain vitamins that are absorbed in the part of the stomach we're skipping, people can get deficient in. And so when you have the bypass, you have to take extra of these vitamins essentially for the rest of your life. As long as you take them, you'll be fine. But if you don't, you can get very sick with it. And then there's something called dumping syndrome you have to be more aware of. This means if you take something that's kind of heavy in carbs or sugars, the body isn't used to processing it now since it's going straight to your intestine. And so it responds by giving a huge dose of insulin. You can get cramping, start feeling nauseous or vomiting, and diarrhea. And so this is something that you hopefully try to avoid by limiting those foods, but still something to keep in mind. So a little more details about the procedures themselves. The sleeve, as we said, a little less complicated of a surgery. So it says here about 40 minutes, and you can actually usually get that between 30, 35, 40 minutes. Most patients stay one night in the hospital afterwards. Bypass, definitely a little more complicated. Usually takes about 2 hours or so to do, and you usually stay 2 nights in the hospital. We don't give specific numbers of weight loss anyone should expect because everyone is different and each person has different goals and needs. But in general, we see about 10 to 12 or so pounds of weight loss per month for the first 8 to 12 months. Again, that'll vary more. People who have more weight to lose tend to lose more faster. Men tend to lose more faster in the beginning, but tends to equal out in the long run. So the process of things from here, most people have started by meeting with a surgeon. If not, you can call our office and we'll discuss with you kind of the options and review your specific insurance requirements. Those will usually include meetings with the nutritionist, these informational meetings, a psychiatric evaluation. Once that's all completed, you get approved, there's still a few more steps to do. At that point, we'll do a medical evaluation to look through any medical conditions you may have. If you need any special workup, meaning if you have a history of lung disease or lung problems, we may send you to a lung doctor. If you have a history of heart problems, we may send you to a heart doctor. If you don't have any of that, we'll probably just send you to your primary doctor for a general clearance. There'll be some lab work we do, which is kind of the general lab work we do for any abdominal surgery. We'll look through your medications, see if there's anything that you either need to stop taking or keep taking. There may be imaging, which your surgeon will tell you specifically for you. Some people might get an upper GI to look at their stomach. Some people might get an ultrasound. If you have a history of stomach problems, we might do a scope study instead. So those will be set specific to each person. A special note there at the bottom to keep in mind is that everyone must stop smoking before the surgery. We actually do a blood test to check for it. So if you're smoking, now is a great time to stop, and that'll have a lot of benefits beyond this on your health. And then as we get closer to the surgery, there is a special diet we'll put you on before the surgery. As it says in the note there, don't worry about these yet because these details will come once it gets closer to that time. But it's not just liquids, but usually a small shake in the morning, a small shake at lunch, and then a small sensible dinner. There'll be a pre-op class, and we'll give you the times for those once you're able to schedule it. And then a final visit with your surgeon where we'll review your lab results and answer any questions you have. And the goal of all of this is to make sure you're kind of fully informed and prepared for the changes that will happen after the surgery. And then once you finish the surgery, there is a staged diet we put you on that progresses back from liquids to regular foods. So long term, you should be eating normal food. There's planned follow-up with your surgeon, which is important. We consider our patients for life, so you can always see us. But we like to follow up just to monitor your progress, see if there's any issues. If so, try to address them sooner rather than later. We'll occasionally check some lab work. This has become less frequent. If it's just a simple stop in to say everything's doing well, no problems, then great. Then keep in mind there are support groups available after the surgery. These are people who've had the surgery and have been living with it day to day, and they know things about how to deal with problems that come up better than even we might. So these groups are free and available to everyone. You don't have to call ahead of time or reserve a spot. You can just show up, and we encourage everyone to attend these as much as they can. So at this time, we'll take some questions.
Yeah, I'll ask a few questions that I often get from patients, like who would decide which surgery you would have? Is it up to the patient or up to the doctor?
It's always a patient choice, but the doctor's job is to direct the patient to the right choice, but ultimately it's a patient choice. each surgery had its pros and cons, side effects and advantage. But the ultimate choice is the patient's.
What if my insurance won't cover the surgery? Can I pay cash, or what happens then?
Of course, if the insurance doesn't cover the surgery, you can pay cash for the surgery. You have to talk to your surgeon's office, or you can talk to Susan Shropshire about the cost, the hospital cost for the surgery. And I think the hospital and the surgeon will make it easy for you to have the surgery done if you don't have insurance.
When can I start exercising or lifting weights after surgery?
You can start exercising from now. You don't have to wait for surgery. Get the habit of exercising, but you can exercise right after the surgery, because walking is the most important form of exercising. You don't have to pay for it. You don't have any effect on the surgery sites. So you can walk from the second day. You can advance walking to running in a couple weeks, and then lifting weights and exercising your abs. It's about like 3 to 4 weeks. For the muscle of the abdomen, the stomach, it's 6 to 8 weeks.
Good. So then when could I go back to work?
Usually it depends what kind of work you do. If you do an easy job, a clerk job, a job that you require you to sit down on the desk, not carrying heavy stuff, I think a week to 2 weeks is very reasonable. But if your job requires heavy lifting or using your stomach muscles, I recommend at least 4 to 6 weeks before you go back to work.
What happens if I get pregnant after surgery?
Try not to. Usually we advise the patients who are able to conceive to avoid having pregnancy for a year and a half after they have the weight loss surgery. The reason is that you're not going to lose weight. You'll be fine. Your baby will be fine. Your baby will get all the nutrition that he or she needs, but you're not going to lose the weight. So you're wasting the surgery. So most of the time, if you taking contraceptive pills as a method to prevent pregnancy, you should stop it a month before and a month after surgery, because it has side effects. Some of them is it causes blood clots. So you have to find another way to avoid pregnancy in that time.
Well, I know somebody who had a gastric sleeve done a couple years ago, and she did really well. She took a lot of weight off and really felt good. Her blood pressure went down. She got rid of her diabetes. She could walk and run and keep up with her kids and her grandkids. But now I notice she's kind of getting heavy again. What happened, and what could she do about that?
I bet you she's not following with her surgeon. You see, so she needs to go back to her surgeon. She needs to go back, run some blood tests, check her sleeve. Maybe she stretches the sleeve out. Maybe she's not eating the right food. Maybe she's not eating enough food. So she might need to see the nutrition, either in the surgeon's office or in the hospital. So she needs to go back on track.
So is there a special diet after the surgery that I have to go on, or supplements or protein drinks or anything?
Yeah, usually there is 5-stage diet after surgery. It starts for clear liquid diet for 3 days, and then full liquid diet, which is creamy food, for about 1 week, and then 1 or 2 weeks full liquid diet, and then you go on to puree food for another week, soft diet for another week, and your on a regular diet. But when we're talking about regular diet, it's all healthy food. So you have to avoid carbs, you have to avoid sweets, you have to avoid fried food and fatty stuff, and protein. You have to get enough protein. Usually you need about 70-80 gram of protein every day. In the beginning, when you are taking clear liquid or full liquid, you can have protein supplement, protein drinks. But later on, when you're having regular diet, then you can have the 80 gram of protein from your diet, from regular food. Vitamins, you have to get your supplement. Like I said before, the sleep, I don't see deficiency with the sleep, but it's always recommended to have your regular vitamins and your calcium. The calcium you need like 500 to 600 milligram twice a day. The multivitamin you need 1 to 2 multivitamins a day. With the gastric bypass, like I mentioned before, you need the multivitamins, the calcium, plus you need B12, which can be either sublingual, under the tongue, or intranasal every week, or injection every month. Also, you need iron supplement, because there is definite iron deficiency with gastric bypass. So you need iron supplement.
So you mentioned that you'd stay in the hospital a couple nights with the gastric bypass. How about the sleeve? And is there a lot of pain with these surgeries or nausea? What can I expect when I go home?
The pain is, everybody's different when it comes to pain. But like I mentioned before, with this laparoscopic surgery, the pain is much less than an open procedure. So that's why we give the patient pain medication in the hospital in the form of IV injection, and then we switch it to an oral medication when they go home. We try to avoid narcotics in the hospital and when the patient goes home. A lot of my patients, they say they didn't even use a prescription I give them when they go home. So
it sounds like the most important thing is going to be to stay in touch with my doctor.
Definitely.
Well, thank you very much, Dr. Attia. We really appreciate your time.
Talk about the water too. You have to drink your water. Because
absolutely,
it's very difficult, but you have to keep trying. You need like 64 ounces of water every day. And again, don't forget to follow up with your surgeon after surgery.
Very good. Thank you.
You're welcome. Thank you, everybody, for listening, and I'll see you again.
Hi, everybody. My name's John Keeley. I'm the Clinical Education Specialist for the Sleep Center and Balance Center over at Inspira. Tonight, we're going to talk a little bit about sleep, the importance of sleep, getting quality sleep, what sleep disorders are, and how to treat those sleep disorders. So what exactly is the function of sleep? There's a lot of different theories out there, such as body restoration, brain restoration, energy conservation, and memory reinforcement. We'll go into a lot of this in the next few minutes. So there's typically 4 stages of sleep that everybody goes through several times a night. You usually get about 2 to 3 cycles of sleep. You start off at stage 1. That's when you kind of hear the news in the background. You can kind of follow along to the story. Deeper sleep is when someone has to call your name a couple times in order to wake you up or get your attention. Deep sleep is kind of a magical zone. It's where your body goes into a healing mode. And there's a lot of good benefit to deep sleep. Stage 4 is REM sleep. It's rapid eye movement sleep. If you've ever seen anybody's eyes move behind their eyelids when they're sleeping, they're in REM sleep. It's where you dream. So typically you start off at stage 1, go down into stage 2, about a half an hour, 45 minutes into it, you hit stage 3, you get a little bit of REM, you come back up to 3, go to 2, go to 1. And typically you'll get about 2 or 3 cycles if you're normal in a normal sleeping pattern throughout the night. So what is the benefit of deep sleep specifically? When you get into that stage 3 sleep, you really get a lot of benefits. Your body goes into what's called a healing mode. So even patients, we're going to talk about sleep disorders, even patients with mild sleep disorders. So a mild sleep apnea patient, for instance, has 5 awakenings per hour. And like I said, it takes about 20, 30, 40 minutes to get into stage 3. So if you're waking up 5 times an hour, you're considered to have mild sleep apnea. But the problem is you're never getting into that stage 3 beneficial sleep. So what happens when you get into that stage 3 sleep? So there's a protein that actually targets infection and inflammation that's released and created in deep sleep. So when you're trying to fight off the cold, the flu, any kind of issues that you're having, you really need that protein to be developed and really take care of those infections and any of that inflammation that's happening. And deep sleep is where that's created. So if you're not getting the stage 3 sleep, you're not getting the benefit of that infection control mechanism that our body has in the creation of cytokine. It's a protein that fights infection and helps control inflammation. Insulin is released. So if you have any trouble with blood sugar regulation, deep sleep is where you get a lot of insulin released. And what it does is it cleans the sugars out of the blood. So even patients that have deep sleep have better control of their insulin throughout the day. So there was the study done recently where patients that had a sleep disorder but were on treatment and had diabetes had 50% better insulin control once they started treatment throughout the day, not just in the morning, but throughout the day, than the subjects that did not treat their sleep disorder. So there's a huge benefit of this big insulin dump that happens at night. And the job of that insulin is to clean those sugars out of the blood. The brain, your body throughout the day, you're burning energy, and your body has a way of just getting rid of that spent energy throughout the day. The brain is probably the most active part of the body throughout the day, and it burns off a lot of different proteins, but it does not go through the same cleaning process throughout the day. The cleaning process for the brain typically happens in deep sleep, once again. So the brain actually settles down when you go to sleep until you get to REM. But while it's settled down, there's spinal fluid that goes in and it cleans out those proteins in the brain. And what that does is it helps keep them from building up. So there are starting to link some sleep disorders with Alzheimer's and some memory issues down the line. So they're starting to really link a lot of sleep with those disorders. So you really want to make sure you're getting that deep sleep. So memory reinforcement. When you dream, a lot of times if you think about what you're dreaming about, it's going to link to something that happened throughout the day. And the theory is that your brain is making it a little bit more of a colorful story and making it a little bit more memorable before it files it away. So that if you ever need to go back and recap what happened throughout the day before, you can remember that. And if you get a good night's sleep before, I know there's a lot of theories out there about doing cramming for a study, for a test. You don't want to do that because you want to get that good sleep. You want to learn what you're doing, you want to study, and then you're going to reinforce that memory by getting into that deep sleep, and your body's and your brain is going to work in a way to reinforce that memory. Cell restoration. So like I said, throughout the day, you're doing damage to your body. You're using it. Just like a car, the more you use it, eventually it's going to start having some issues. Well, your body needs that break at night to help restore some of that cell damage that you may have done. So at deep sleep, once again, you're releasing very good new cells, and they're helping to replace some of those damaged cells. So once again, there's another hormone. Ghrelin is a hunger hormone. So when you're feeling hungry, this hormone is being released. When you're not sleeping, it's kicking into high gear. When you're in a stressful situation, it also releases this hormone. So if you have a sleep disorder, your body goes into a fight or flight response. And this hormone is really kicked into high gear. So that's why a lot of times people will wake up in the middle of the night and they're getting a midnight snack, or they wake up in the morning and they're extremely hungry and eat these huge breakfasts. It's good to get the body going throughout the day, but you really shouldn't be that hungry. Leptin is what kicks in when you get into deep sleep. So typically throughout the day, you're not going to go 8, 9, 10 hours without eating. But when you sleep, you can. That's because ghrelin is contained, it's turned off, and leptin is kicked in. And leptin actually will reduce those hunger hormones. It makes you feel full. So that's why you're going throughout the night and you're not waking up to eat, because you're not hungry. That hormone is keeping you from being hungry. So it's a great thing that happens at night, and it really helps speed up the metabolism. So even after we go through surgery or weight loss, you do want to keep up with treatment if you were put on treatment, because it's going to help this hunger hormone relationship, and it's going to help you do better with your diet. And the heart. So there's a lot of studies out there that are linking sleep disorders to different heart issues. And we'll go over the prevalence of this later on. But what happens in deep sleep is your body takes a break. Your respiratory system slows down, your heart rate slows down, and it essentially gives your body a break. The heart gets to take a little bit of a rest. Throughout the day, you're running, you're going, heart rate's up, energy levels up, your respiratory rate's up. You need to take a break. Just like a computer, when it starts acting a little bit glitchy, you need to turn it off a little bit and then turn it back on. Once you turn it back on, usually those issues resolve. Same thing with the heart. It gets to take a little bit of a break. Your regular heartbeats are taken care of. It really helps out quite a bit. So like I said, if you even have a mild sleep apnea case of 5 awakenings, that's waking up every 12 to 15 minutes. It's not giving you that chance to get into that deep, restorative, healthy sleep where your body recovers. Your body just really needs to take a little bit of a break. When you do have a sleep disorder, like I said, you have a fight or flight response. So your heart rate stays elevated. Ghrelin is still kicking in, that hunger hormone. Leptin doesn't get a chance to take over, so your metabolism stays elevated. And it doesn't give you the chance to clean out the sugars in the blood. If you feel a little foggy in the morning, your brain's not getting that cleaning process. So a lot of patients I talk to will indicate that they had a sleep study done, but it only indicated that it was a mild case, and we really didn't feel like there was a need to take care of anything. But no, if you have even mild sleep apnea, you're not getting these benefits. So really take the treatment seriously if it's something that's prescribed to you. So how well do we sleep in general? We're working a lot, we're playing a lot. We typically do not get enough sleep. We need to get about 8 to 9 hours a night. And if we're lucky, we're probably getting about 7 hours. And it really shows that the true benefits of a good quality sleep, all that stuff that we were talking about, to get the full benefits, all that deep sleep, you need to get a solid 8 hours. So really make the time to allow yourself to get those 8 hours, and make sure that if you were tired after getting those 8 hours, that you're talking to your doctor about what might be going on. What's making you feel fatigued after getting 8 solid hours of sleep? That's when we're going to look and see that there might be an underlying sleep disorder that we can take care of. So what are some things that will disturb your sleep? Stress. Nobody has any stress, right? Even before doing a presentation like this, the night before, I never sleep well because I know I got to be on my game, and I stress out about it a little bit. So stress will disturb your sleep. Change in environment. If you live in the city and you go out to the suburbs, it's way too quiet. If you go from the suburbs to the city, it's too noisy. And it takes time to adapt to that new environment, and it will keep you from getting sleep. Poor sleep hygiene. That's not taking a shower before going to bed. That's keeping the same sleeping hours, going to bed the same time every night, getting up the same time every morning. There's something called restless leg syndrome and periodic limb movement. That's where your body involuntarily moves throughout the night. If you're awake and you're smacking your partner, that's a different problem. But if you're doing it at night when you're sleeping, it could be a sleep disturbance. Obstructive sleep apnea is the one that we're really going to focus on today. It's the most common sleep disorder that's out there. So we'll go into some great detail with that. Central sleep apnea is where your brain just forgets to tell you to sleep. It may sound strange, but your brain doesn't tell you to breathe while you're sleeping. That's something called central sleep apnea. Some patients actually are unlucky enough to have both obstruction and centrals. Those patients are called complex sleep disorder patients. And then medications. If you start taking a new medication and suddenly you find you're having trouble sleeping, talk to your doctor, not about maybe adjusting the medication, but maybe even the time that you're taking it. Some medications are stimulants for some, and for others, it'll make them tired. So every medication may be different with every person. But if you start taking a medication and you find that you're not sleeping very well, talk to your doctor about that. So what is proper sleep hygiene? Typically, it's going to bed same time every night, waking up same time every morning. But there's also some nesting things you can do, things that you can do to tell your body that it's time to go to sleep. And if you go to bed and you're not tired, your body's not going to relate the bed to going to sleep. So first point is to go to bed when you're tired. I know that sounds strange, but you don't want to go to bed to watch TV, get on social media, or read, even reading a book. You want the bed to be the place that you go to sleep. Avoid heavy meals right before bed. What happens if you take a heavy meal? You're giving your body all this energy, and you're going to want to burn that energy off. So avoid the heavy meal right before bed. It also will cause some heartburn. GERD is a problem if you have a heavy meal right before bed. You lay it down, and it tends to want to come back up, and it'll give you some of that heartburn. So there's a couple of things that happen at nighttime that get your natural circadian rhythm going. At night, the temperature goes from warmer to cooler. The sun goes down, it gets darker. So you want to mimic that. If you're having trouble going to sleep, you may want to take a warm bath or a warm shower. That will actually raise your body temperature. When you get out, your body temperature drops off and it tells your brain it's actually nighttime. And if you can keep the room as dark as possible, that's always going to be helpful as well. If you're a daytime sleeper, if you work night shift, make sure you have room darkening shades. Turn your alarm clock around. You don't want that alarm clock facing you because it's going to be a light stimulant, and it's also going to have you stressing out. You're going to see how many, if you wake up at 2 o'clock in the morning, you're going to say, I have 2 or 3 more hours of sleep. And you start stressing about that. And like we said, stress is not conducive to getting to sleep. If you're unable to get to sleep within 20 minutes or so, find something relaxing to do. Get up, go to another room. If you're going to read, just have a dim light. Do some reading until you start feeling that heavy eye. Once the eyes start getting heavy, then go back into bed. You can even do some soothing music if you don't want any light stimulation at all. And that sometimes helps. And like we said, keep that sleep schedule, even on weekends. And I know if you're a shift worker, you're not going to do that on the weekends. You're not going to stay up all night and sleep during the day. So that's something that it's already a category of a sleep disorder. It's called shift work disorder. Talk to your doctor. There are some medications that can help. And if your primary care is not comfortable working with those medications, ask for a board certified sleep physician in your area. And at the end of the presentation, we'll actually go over some of the ones that are local to us. So what to avoid right before bed? Electronic devices. Right now, we're seeing a lot of teenagers that are having insomnia issues because they use the electronic device right before bed. They're on Facebook or any of those other social media platforms. That light stimulation is telling the brain that it's daytime. It's also a stress inducer because a lot of times you're on these social media platforms and it's not all puppy dogs. Sometimes there's some stressful information on there and you get that stress, you start thinking about all this stuff, your brain's taking it all in, and then you're just going to go to sleep. It's not going to happen. Strenuous exercise is wonderful in the morning, even in the afternoon. It gives the body that boost that you need. It gives you the energy. It can even replace caffeine. But doing it right before bed, if you have issues falling asleep, it may be because you're pumped up now. You're raising that energy level. You're getting your body all hyped up, and then you're just telling it to turn off. And sometimes it's not going to happen. It's not going to let you get right into sleep. If you're having issues, avoid strenuous exercise right before bed. Napping is fine. There is some science behind the siesta. Around 3 o'clock, taking a little 15, 20-minute nap. There's a lot of studies are showing that productivity goes up after that. I still try to convince my boss of that, but it's not happening. But there are some benefits to it. What you do want to avoid, though, is you don't want to get into REM. Once you get into REM, which is at stage 4 of sleep, your body thinks you're going to sleep for the night, and it's going to hinder you getting to sleep later in the day. So a 15-minute, you should be in stage 2, maybe a little bit of stage 3, and then you're waking up. That's okay. But any longer than that, science shows that it will actually hinder your ability to fall asleep later on. So a short nap is fine. I did a health fair before, and I had a woman come up and say she could not fall asleep at night, and she was retired. So I said, "Do you take a nap?" And she indicated that she does. I asked her how long, and she was taking a 3-hour nap every day and then trying to go to sleep at night. It's not going to happen. Your body thinks you already went through that sleep cycle, and it's really going to throw off your circadian rhythm. So you also want to avoid caffeine, nicotine, and alcohol. Alcohol, sure, it might knock you out, but it turns into a stimulant later on. So it will actually keep you awake. So that little nightcap that you might have might help you fall asleep initially, but later in the night, it's going to wake you up, and it's going to be it's going to hinder your ability to get in that deep sleep as well. And like I said before, large number of alarm clocks. They're stress inducers. You wake up, you see that, and you think, oh my God, I got to get back to sleep. And it's also a light stimulant. So turn them around or even get them out of the room. We all have cell phones now. We can silent them and make that our alarm clock. But that way we're not staring at that number when we wake up. So what are some common sleep disorders? Obstructive sleep apnea, like I said, we're going to go into that in quite a bit of detail today. Central sleep apnea, that's actually more commonplace than cardiac patients. Complex sleep disorders is a combination of both obstruction and central. Restless leg syndrome or periodic limb movement is that involuntary motion that you have at night. Right before you go to bed, if you start feeling creepy crawlies in the legs, that's restless leg syndrome. Narcolepsy is when you fall into REM. We get to categorize narcolepsy or to diagnose it. We have to see that a patient falls into REM within 20 minutes of going to sleep. So there's actually a study that we can do for narcolepsy where you come into the sleep lab, we have you tested at night to make sure you're getting good sleep, and then we do 5 series of naps after that. And if you fall right in the REM, it's considered narcolepsy. So some patients will actually have it with the stress-induced narcolepsy, where there's a stressful environment going on, and suddenly they crash right into sleep. We talked a little bit about shift work disorder, and it's tough because there's little you can do. We need you shift work disorder people. We need you out there at night doing the vital jobs in the hospital fields, police, firemen. It's sad, but it's considered a sleep disorder, but we need them. Insomnia, when you just can't fall asleep. And there are some medications you can take for that, but if you have a sleep disorder, sometimes it relaxes the muscles. So you really, if you're taking anything for insomnia or if you have any insomnia, we can't test that you can't fall asleep. So you really do need to see, once again, those board certified sleep physicians to help you with insomnia. Night terrors and parasomnias, we'll keep them in the same category. It's any acting out at night. We've all heard about people waking up and making a meal and going back to bed and not having any memory of it at all, or sleepwalkers, or night terrors, or acting out their dreams. These are all parasomnias. So sleep paralysis is another one as well, where you wake up. I've had people come up to me and say they felt this. They wake up and they feel like they are paralyzed. Well, in REM, your body, your muscle tone is actually, it's not moving. You do not move at all in REM. So if you're waking up straight from REM, sometimes when you get in that stage 1 sleep, you're aware, but your body hasn't caught up yet. And you do feel paralyzed. So it's a common disorder. It's nothing to be worried about. But once again, you want to talk to a board certified sleep physician. So in all, there's over 80 sleep disorders that are out there. Most of these sleep disorders can be determined in a sleep lab. Like I said, insomnia, we can't test for. But there are also a lot of insurances that are limiting what we can do to home. Home studies are convenient, but they tend to lower the severity of a sleep disorder and it's limited to respiratory sleep disorders. So if you have any other issues besides waking up gasping or snoring or respiratory related, you really want to have it in lab. And if you get a negative home study and they say that you have maybe 4 events an hour, home studies have a tendency to lower the severity of a sleep disorder. So if you still have symptoms after having a negative home study, talk to your doctor about coming in for an in-lab study. And they can sometimes work with the insurance to get that approved. It is a much more comprehensive study, and the home studies will do in identifying respiratory sleep disorders. But like I said, it will lower that severity. So if you come back mild, you might be moderate, and vice versa. If it comes out negative, you might have a mild case of sleep apnea. Just work with a doctor that knows what they're looking at when they see a home sleep study compared to an attended sleep study. So like I said, we're going to spend a good amount of time on obstructive sleep apnea. And as you can see in the pictures, class 1 is an open airway. You can breathe freely. There's no issues at all. Class 2, it's a little bit more restrictive. Class 3 is where we really start getting some compromised airways at night. And stage 4, usually if this is a pediatric patient, the tonsil adenoids come out in the stage 3 or stage 4. But if your doctor even sees this and you have some of that gasping at night, it's something that they might want to look at and say, let's get you tested. Let's find out what's going on. Snoring, a lot of times I sleep like a log at night. And I hear him snoring in the other room. He sleeps wonderfully. Snoring is a big indicator of an obstruction. When you snore, somewhere in your respiratory system, you're breathing through skin on skin. These images show that your tongue will sometimes connect to that skin that's in the back of the throat, and it'll block that airway. When you breathe through it, it tends to vibrate and it causes a snore. A light snore might be okay, but a louder snore, or even worse, a snore that stops for about 10 seconds and then gasping for air, that's a real concern. That's a witnessed apnea. So just be aware that this is a condition that's very common and it's very treatable. So what are some symptoms? Like I said, the loud snoring. If you can hear someone snoring in the other room, that tends to be a little bit too loud. Witnessed apnea is where I said you stop breathing and then suddenly you have that choking and gasping, that awakening. That's an indicator that there is an obstruction going on. We just need to know how severe it is. Excessive daytime sleepiness. If you're falling asleep in meetings, if you're falling asleep during this presentation, it may be my voice, or it may be excessive daytime sleepiness. Morning headaches. If you have a sleep disorder, you're blocking oxygen from getting to the brain. So a brain that's starved of oxygen tends to hurt in the morning. So morning headaches are another indicator. A strong desire to nap during the day. If you get done with work, I know if you're working heavy lifting and all that kind of stuff, you're going to be tired at the end of the day regardless. But if you come home and you just feel like taking a nap on the couch and you just need to get that 10, 15-minute nap, that's an indicator. Irritability or mood swings. If you're not sleeping, if you get one bad night of sleep, the next morning you're not a happy camper. So imagine a person that's having this every single night. You're going to be irritable. You're going to have these mood swings. Reduced sex drive or impotence. Forgetfulness. Remember, we were talking about memory reinforcement in sleep. If you're not getting that deep sleep, you're going to have a lot of forgetfulness. Unexplained accidents or errors, especially at work. If you ever see a tractor trailer or a train or any kind of big accident, give it a day or two, and normally it'll come back that it's driver fatigue that's related. So even patients that are commercial drivers, a lot of times we're screening those patients for a sleep disorder to make sure that they're getting good quality sleep at night. So some physical attributes of sleep disorder: obesity. For men, if you have a 17-inch or neck or larger, for women, a 16-inch neck or larger, that's going to hinder that airway. It's going to restrict it a bit. Large tonsils and adenoids. A lot of times with pediatric sleep disorders, the first stage of defense is we take the tonsils and adenoids out. And a lot of times before they can do that surgery, they have to do a sleep study to show that there's an actual sleep disorder. And like we saw a couple slides ago, all that stuff that's in the back of the throat, the uvula, the soft palate, that can all restrict the airway along with the tongue falling to the back of the throat. And small jaw is another indicator. So what are the effects? I don't get a good night's sleep, so I'm a little bit miserable on the next day. So what? Not a big deal, right? No. If it's prolonged, it comes with a lot of different issues. A lot of health issues come along with sleep disorders. So high blood pressure. If your heart is never getting a chance to relax, your blood pressure is eventually going to start spiking, start going to go up. And if you have an elevated blood pressure, you're going to have an increased risk of stroke. There's an increased risk of heart failure. You start getting irregular heartbeats. Heart attack is increased. Remember, these are all stress hormones. When you're having these sleep disorders, it's stress hormones being released at night. You're not getting that chance to just give the heart a little bit of a break. Diabetes, like we indicated, if you're not getting that insulin release, your sugar levels are going to become unregulated. Depression or worsening ADHD. Surgical complications. So this is one of the main reasons you're possibly being screened and sent in for a sleep study. If you're having surgery, they need to maintain that airway. And even your recovery, you're going to need to take that equipment. If you were prescribed equipment, you're going to bring your equipment with you the day of surgery because you're going to need it for your recovery. You don't want to have a compromised airway as you're trying to heal. You want to get into that magic stage 3 zone. So make sure that if you were prescribed a CPAP, you bring that unit with you to the hospital the day of surgery. We want to avoid surgical complications, and I'm sure you do too. Weight gain. We talked about the hunger hormones, the one that causes hunger, the one that keeps hunger hormones at bay. They're at night, so it's going to affect weight gain. So what comes first? Did I gain some weight and it caused sleep apnea? In some cases, yes. But then that sleep apnea is causing an increased weight gain. And even after you have surgery, you want to continue your treatment because it's going to help with your weight loss goals. It's going to help with your weight, your diet, and your exercise. Worsening disease state. Any disease that you have, if you have a sleep disorder, almost all of them are indicators that a sleep disorder is going to make that condition worse. There was a study done with, I hate that they did it with mice, but they did. They injected cancer cells in the back of mice. They kept half the subjects awake. They didn't let them get into their circadian rhythm. They let the other half sleep normal circadian sleep patterns. The ones that were kept awake, the cancer spread rapidly throughout the body. Doesn't indicate that the cancer was caused by the sleep disorder, but the ones that were able to sleep, it stayed at bay. It stayed where they injected it. It did not spread, and it was contained. So worsening of the disease state happens with a ton of different things: heart issues, diabetes, all these other, hypertension. All of these are worsened with sleep disorders that are left untreated. Acid reflux. If you're snoring, if you have that blocked airway, we tend to get some acid reflux as well. Memory loss. They're starting to link that cleaning process that happens in deep sleep to a lot of memory loss down the line, and even some Alzheimer's. And reproductive problems. So this slide is just a slide indicating how much it is prevalent with each disease state. So 72% of type 2 diabetics have a sleep disorder. 77% of obese patients have a sleep disorder. 30% of cardio artery disease. Now, this is a big one. Congestive heart failure patients. We're starting to screen them in the hospital because we need to avoid them coming back in the hospital for their congestive heart failure. 76% of the patients that have congestive heart failure have an underlying sleep disorder. 70% of strokes. A lot of times strokes happen at night because you're going through that fight or flight response. So 70% of stroke. And hypertension, it's 37% for the general population. But when you get into multiple medications for hypertension, that number goes up. So the prevalence in sleep disorders and all these comorbidities is very high. But the good news is that if you treat the sleep disorder, it's going to help all these other health issues that you're experiencing or may be experiencing. It will also help you avoid getting into these states in the first place. So an in-lab study, like I said, is a lot more comprehensive than an at-home study. At home's a little more convenient, but here we're getting 36 leads of information. We're seeing brainwave activity. We're seeing heart rate. We can see if you're snoring. We can see when your oxygen levels are dropping off. We can see when your heart rate is elevated. So we're getting all this information. We can see when you're trying to breathe and nothing's getting through. We can also see if you're making no effort at all to breathe and your oxygen levels are dropping off. That's how we detect essential sleep apnea. We can also detect any movements that are going on throughout the night. We have leads on the legs, so we can get restless leg syndrome. And we can see everything that's going on throughout the night. So what do we do when we see a patient like this? They're having events every few minutes, and it's just waking them up over and over and over throughout the night. Not exactly a good night's sleep. What we do is we'll wake that patient up in a sleep study, or we'll have them come back again and we'll put equipment on them. The next slide will show you what the patient looks like once they are treated for their sleep disorder. So this is a patient that's put on CPAP that opens up that airway. CPAP is continuous positive airway pressure. There's also BiPAP, which is 2 different levels. So continuous is 1 set pressure. BiPAP is 2 pressures, 1 for when you inhale and 1 for when you exhale. There's something called ASV, and that's for those complex sleep disorder patients that have both central sleep apnea and obstructive. And that equipment, it's still positive airway pressure, but it will actually induce a breath. So if your body forgets to breathe, it'll actually blow some air in there and open up that airway and remind you, you need to breathe. So all this different PAP being introduced into a patient's sleep condition, this is the way a good night's sleep should look. You have normal heart rhythms, your breathing's normalized, your brainwave activity settling down. So you're getting a good restorative night's sleep. We can even tell what stage sleep you are in. Can't do much of that with a home study. With a home study, we know your oxygen level. We know if you try to breathe and if you're not trying to breathe. We can tell if you're snoring. And there's a couple leads that just help indicate any respiratory issues or distress. We can pick up some heart rate, but we're not picking up a lot of the other indicators that we can in a lab. But it is a decent screening tool. So if you wind up with a home study because your insurance denied the attended study, understand that we are still going to be able to capture a respiratory issue, which is the main concern before surgery. So treatment for a sleep disorder. Typically, most patients will go on that positive airway pressure. 90% effective, that's because 10% of the patients just can't get used to it. They don't give it enough time. They don't give it a chance. So we'll go into some slides a little later that show that there are a lot of different options for masks. And that's usually the hardest part. And what patients don't usually realize is that when you're set up on CPAP, you're given a mask to use. That is not your only option. And usually most insurances will allow you to switch that mask out without going through another billing charge. You're not going to have any copays within the first 30 days because they want you to get used to this equipment. So when you get a CPAP, if you get a CPAP, if you're not happy with the mask, take notes and call the DME company, the company that brought the equipment out to you. Call them and let them know what you're experiencing, what you like and what you don't like. And typically they're going to find an interface that's going to help you get used to using this mask. So that's why it's down to 90%. It's really typically 100% treatment effectiveness. Surgery is tonsils and adenoids being removed. That's usually the first line of defense for pediatric. For adult, not so much. Mild sleep apnea cases, sometimes there are some things that could be removed that will help with the sleep disorder. And it's about 40% effective for about 40% of the mild sleep apnea patients that have surgical interventions. And typically you'll work with an ENT and they'll be able to look at your physiology and see if removing that will help or not. There's also dental appliances. Once again, it's about 40% effective for mild to moderate sleep conditions. Severe, it's not really going to help out too much. There is an implantable device that everybody thinks Inspira does. It's called the Inspira, and that's almost like a pacemaker. It's implanted underneath the skin. It is invasive, but it's more for the severe sleep apnea patients that just can't get used to CPAP. But it is life-sustaining that they take care of the sleep disorder. It's going to not have great outcomes if they don't treat it. So if you can't get used to CPAP, you have a very severe case of sleep apnea, An implantable device is what is an option for you. They implant the device under the skin. They have 2 leads that go to the rib cage that can tell when you're trying to breathe. And there's 2 leads that go to the back of the tongue that will actually tighten up that muscle and push the tongue forward. So it keeps that airway open. Sounds very invasive, but if you have severe sleep apnea, you have to have treatment for this. And if you can't get used to CPAP, you need to use this device. But using this, talking to your doctor to find the best treatment plan is what you need to do. And if your primary care is not comfortable managing your sleep disorder, or if you have trouble getting used to the CPAP itself, or if they're not even comfortable sending you in for a sleep study in the first place, you're going to want to go to a board certified sleep physician. So check into that. Make sure that who you are seeing is board certified in sleep. There's certain criteria that they need to meet in order to become a board certified sleep physician. So these are just a few of the CPAP masks. If you Google CPAP mask and click on imaging, you're going to see a ton more that are out there. But typically we have nasal pillow, which just goes into the nasal cavity. There's one that covers the nose entirely. That's called a nasal pillow. If you're a mouth breather, sometimes you need what's called a full face mask. They're the 3 that are the most common. The full face mask goes over the nose and the mouth. There's some that are a hybrid. It's like a nasal cannula and a mouthpiece as well. And there are some that just go into the mouth. And it depends if you have facial hair, sometimes that's better. So once again, primary care physicians may not know the full range of mask availability, but a board certified sleep physician will know exactly what's out there, any new equipment. Those manufacturers make sure to target those sleep specialists and make them aware of what is available to them. There's also a lot of different CPAP units that are out there. There are some that are portable. Insurances typically do not pay for portability. So these are usually the 3 main manufacturers that are out there. And PAP, positive airway pressure. It's essentially just a pump that's blowing air into your lungs. They all have different bells and whistles, and your doctor can refer you in for a specific machine, or it could be up to the DME company, that company that brings out durable medical equipment to you. They're the ones that are going to bring the CPAP to you. The main thing that you're going to want to concentrate on, though, the mask, is what's going to be the problem. If you're going to have any trouble getting used to it, you're going to want to really focus in on that mask. CPAP units typically will do the same thing as the other CPAP units that are out there. There's not much difference in there. There's a couple different things that some do that others don't, but typically it's the mask interface that's going to be the main hindrance of you adapting to CPAP use. So like I said, adjusting the CPAP, it only works when you use it. It could take a little bit of time to get used to using it. Some people, if they have a severe case of sleep disorders, when they get put on treatment, they want to take that equipment home with them that day. Typically because it's the first time they got into deep sleep and REM in years. They're the patients that typically do very well with CPAP units. It's more the mild cases where you're not going to see as big of a benefit to the sleep for getting a quality night's sleep. You want to keep with it though. It can take up to 6 weeks to get used to using a CPAP. Any new habit, it takes at least 40 days for you to get accustomed to that new habit. Give it time. There's even some applications that are out there. Some of these manufacturers have apps where you can track your own sleep progression. And patients love that because they can see, I'm doing a good job. Look how much sleep I got. A family member of mine actually was put on one recently. And they came and they showed me the reports. They were all excited about it and they were feeling so much better. So give it time. It does take a little while to get used to. There are some support groups that are out there. Even if you go online and just say, hey, I'm new to CPAP. Does anybody have any experience with this? You're going to see that a lot of your friends that you may not have been aware of are on this equipment. And they're going to tell you, some of them are going to tell you how great it is. Some of them are going to say, I tried it for a week and couldn't put it in the closet. Don't be that second group of friends because that treatment is needed in order to avoid all those other health complications. And yes, it does take a little bit of time, but give it a chance. So when to see your doctor, either when you have equipment or even before you're even diagnosed with a sleep disorder. Everybody has a bad night of sleep every now and then. But if it persists for more than 2 weeks, that's a problem. If you're on equipment and you start seeing that you're having trouble sleeping, your equipment may need to be adjusted as well. So if you're having issues sleeping and it goes on for more than 2 weeks, talk to your doctor. And once again, it's going to be all those symptoms that we talked about before: falling asleep while driving, difficulty paying attention, snoring, causing issues at home. If you're on a CPAP and you start snoring, that pressure is no longer the right pressure for you. They need to adjust that equipment pressure for you. If you're falling asleep at inappropriate times, or if you have any of the other risk factors that we talked about. If you're on CPAP, and now this is key. If you have a 10% BMI change, body mass index, you're going to need to adjust that pressure. There is something that might be more conducive to having bariatric surgery. You're having a surgery, you're going to start losing that weight. What we want to avoid is you stopping treatment, because like we said, it's going to help you reach those weight loss goals even quicker if you keep up with treatment. So your doctor, knowing that you're going to be losing this weight quite rapidly in some cases, may suggest that you go on to AutoPAP, which is one that we didn't discuss. What AutoPAP does is it finds the right pressure for you at any given time, and it will adjust as you lose that weight. Now, it's a little harder to get used to AutoPAP, but if you're in a situation where you're going to be doing some weight loss, it may be a better long-term solution. So even if you get put on a CPAP at first to get used to the equipment, being put on AutoPAP afterwards will help you adapt to the new pressure as you lose that weight. So some things you can do, and you're doing it if you're in this meeting: weight loss. That restriction in the airway, if you start losing some weight, that airway is going to start opening up a little bit more. It may not get rid of the sleep apnea all the way, and that's where the CPAP is going to help, but weight loss can help lower the severity of that sleep disorder. Reduce alcohol and avoid drugs, certain drugs that are out there that are going to relax the muscles. When those muscles relax too much, that's where that restriction comes in. The tongue falls to the back of the throat, and it actually will block that airway. Sleeping on your side. Before we had any of these CPAP machines, what did we do? They actually used to sew tennis balls into the back of shirts, and that way you're sleeping on your side. And it's all a matter of gravity. If your tongue is falling to the back of the throat, or any of that mass that's around your throat is blocking the airway, when you're on your back, it's going to be more severe than if you're on your side. It's not going to cut off that airway as much. So sleeping on your side can help lower the severity. Doesn't get rid of it, but it does help. Stop smoking. And if you're in this meeting, you should have already stopped smoking. Your doctors are going to check and make sure that you have. But what is it related to sleep disorders? It actually is an inflammation. So if you already have a restricted airway, that smoke is going to inflame that tissue even more and block off that airway even more. And you can keep a sleep diary. Talk to your doctor. Let them know how you're feeling. If you're waking up in the middle of the night, write down what time you're waking up, how you're feeling. If you feel like you were gasping for air, if your heart rate's all elevated, write it down and talk to your doctor about it. There's two things that doctors always talk about: diet and exercise. But sleep is that third component. There's 3 pillars of health. Sleep is a major component, and sleep will help you with the diet and exercise as well. So like I said, sleep and diet. We already talked about the hormone regulation. Those hunger hormones are suppressed at night. So you're not hungry at night. You're waking up, you're not starving. And leptin is kicked in. That will tell your body that you are full. It keeps you from getting hungry. Those 2 things alone are going to help you so much with the diet. And you also, when you're tired, what are you hungering for? What is it that you really want to eat? You want to eat those carbs. You want to eat the sugars. You want to eat the candies, the coffees. And that's all giving you that energy boost. It's great, but it's also going to put on those pounds. So you're craving the wrong food. So when you're trying to diet and you're sleep deprived, you're not going to make the best of choices. It's also going to help you stay on track. If you're sleeping well, you're going to wake up, you're going to have that mental capacity to keep on that regimen of a good diet. And it's also going to help with a healthy metabolism. So it will keep that metabolism sped up and it'll burn off those calories that you are taking in. So exercise as well. We talked about cell restoration. So when you're exercising, you know, the first couple times you're getting into that exercise routine, you get back from the gym and you're sore as anything. Okay, your body's not used to it. But at night, your body's going to help you recover from that. And the more you get into it, you're going to get over that pain real quick and you're going to start feeling that energy from exercise, not from the caffeine and the sugars. The muscles that are sore, if you're in a deep sleep pattern, it's going to help with that soreness as well. It's also going to give you more energy. If you're not sleeping, you're not going to have the energy that you're going to need to go for that run, to go to the gym, to get out there and work out. And it's also going to help you stay more regimented in your exercise routine. So a normal sleep cycle is also tied into a normal exercise cycle. You want to try to exercise so your body knows it's coming up, same time every day. There's also some studies that are coming out about eating the same times every day. And your body gets used to that. It's almost like a circadian rhythm for exercise and for diet as well. You want your body to get into those routines so your body knows what to expect. You're not going to eat in the morning and then one day you're going to not eat the rest of the day. Then the next day you're going to eat lunch, dinner, snacks. It's going to throw off that timing. Your body's not going to know what's going on, and it will tend to store some of that fat. So you do want to keep on a regular eating schedule, regular exercise schedule, and a regular sleep schedule. So we were talking a lot about board certified sleep physicians that are in the area. And at Inspira, we only work with board certified sleep physicians. So all of our reading panel is comprised of board certified sleep physicians. The ones that we work with, Dr. Belli, he's located in Hamilton and Elmer. Dr. Breen, he's located in Woodbury and also in Mulliga Hill. His partner, Dr. Chen, also in Woodbury and Mulliga Hill, all board certified in sleep. Dr. Kanoff also works in Hamilton and Elmer along with Dr. Belli, board certified in sleep, internal medicine, pulmonary. Dr. Mattel is located in Vineland. Once again, board certified in sleep. Dr. Rosenberg, he's partners with Dr. Breen and Dr. Chen. He's in Woodbury and Mulliga Hill as well. So we have a lot of choices for board certified sleep physicians in this area. Make sure you're working with the board certified sleep physician for your sleep needs. We also have a video. This is Shaquille O'Neal saying in 5 minutes what it just took me, 45 minutes to do. So enjoy the video.
I snore?
Yeah.
See, I don't know if I snore because I don't hear myself, so.
Oh, he hears himself because sometimes it wakes him up. And he's like, baby, was I snoring? Yeah, you were snoring. It usually happens when he's on his back, and then he gets into that deep snore like it's deep. And then he stops. His chest would stop moving and everything, he was not breathing. So I nudged him like, babe, wake up. And then he'd catch his breath. I'm like, dude, you just stopped breathing in your sleep. And I saved him.
Pam's a registered polysomnographic technician.
Poly what?
Polysomnographic means sleep study. She'll be the one putting the electrodes in.
Sleep apnea actually is a pretty common condition, which is most likely underdiagnosed and underevaluated because many people don't realize that they have it.
Well, every time I stop breathing, she's, the next one, yeah, sleep apnea. Yeah, sleep apnea. And I'm like, what is sleep apnea?
Well, sleep apnea is a condition where a person is unable to get air into their lungs when they fall asleep.
Every time the person stops breathing, they wake up. They stop breathing, they wake up.
And that exposes the body to a myriad of really adverse stresses.
And that does have consequences.
Irritability, can't focus and maintain attention.
They're unable to sleep in the same bedroom with their bed partner or spouse.
There's about a 7-fold increased risk of motor vehicle accidents.
It's linked with the obesity epidemic to being linked with cardiovascular or heart disease.
High rates of stroke, diabetes, and even mortality.
And so now we gotta fix it. Don't want to go out like that.
So, Shaq, one of the things that we talked
I'm meeting with the sleep doctor, my main man, Dr. C. He said he wanted me to be part of his sleep study.
We arranged for an overnight recording in which we could actually find out whether Mr. O'Neill has sleep apnea.
So tonight, electrodes on the head, and they're going to study the brain waves. Hopefully my REMs and my non-REMs. See, I read that, my rapid eye movements.
Oh, and the end of the what?
Non-rapid eye movement. So, hopefully I don't have it, but if I do have it, I know I'm working with the best people to, get it cured.
You all ready to go to sleep?
Yes, sir.
Okay, good luck with everything. We'll be here monitoring.
So the evaluation of sleep apnea is a test while they're asleep. And every second of the study will be looked at, and then the physician will interpret it and make a conclusion.
To cut to the chase, you have moderate sleep apnea here.
Obstructive sleep apnea is a chronic condition which is eminently treatable.
All right, so you said there's the mask, the mouthpiece, and surgery.
Correct. The treatment of choice as of today for sleep apnea is to go ahead with nasal sleep apnea mask.
And is this forever treatment or just a 6-week thing?
We generally regard this as lifelong treatment.
Getting a mask to fit effectively is often a cardinal part of effective treatment.
You have a mask here that I can look at?
If a person is able to use the CPAP device, it works almost 100% of the time.
Oh yeah, this is pretty good. This is nice, I like it. Can I wear it to the club?
Yeah, absolutely.
Oh, this is nice.
Okay.
I like it. I'll do it. Since I've met with Dr. C, and I've been getting at least 7, 8, 9 hours of sleep a day. Feel good. The weight is good. Got a lot of energy. The relationship is good at the house. Everything is working.
All right, so we're going to get started with some question and answers. So I'll turn it over to Susan Shropshire, our bariatric coordinator.
Hello, everybody. It was a great video and production by John. We have a few questions of him today. If a patient is on CPAP or AutoPAP and has their bariatric surgery and loses weight, when should they either be retested or when can they know to go off CPAP?
So they're always going to want to work with their doctor that prescribed the CPAP in the first place. And sometimes the bariatric surgeons will prescribe the CPAP, but then turn you over to a sleep specialist. That sleep specialist is going to be able to monitor the machine. They're going to know that they need to adjust it. In some cases, they may have you come back in for another sleep study. But in other cases, they can simply adapt to the pressure change or turn it into an AutoPAP. So you may not need to come back in for another study. As far as getting off of the equipment, as the weight comes off, there is a slight chance that you may sometime down the line be able to get off of the treatment. But until then, you want to keep up with that treatment because, like we said, it's really going to help enhance those weight loss goals, both with diet and exercise.
I would think that would be reason enough to keep taking it. Absolutely. Yeah. What if the patient had their study close to the time of surgery and they haven't gotten their equipment yet? I hear that a lot from patients. What should they do?
Sometimes I know the surgeon will actually delay the surgery a little bit. So when you get that initial call to schedule your sleep study, answer that call as soon as possible. It does take some time for the authorization process to take place as well. So you want to get that process started as soon as possible. Get the call, schedule your study, and hopefully by the time you get diagnosed and need the treatment, you'll have that equipment in hand so we don't have to delay the surgery at all.
And for those patients who feel they can't handle the CPAP with any of the devices, they've asked me about a surgery they can have.
So like I said, there are some surgical interventions that can take place. If it's a moderate to severe case of sleep apnea, removing any of that in the back of the throat is really not going to do anything more than maybe lower the severity a little bit, but it's not going to get rid of that sleep disorder. There are the devices that we spoke of. It's called the Inspira. There's a couple other ones out there. What that does, it's a surgical intervention. But if you're going to be losing the weight, I don't really recommend that because you're going to go through all that and eventually you may not need that intervention and you went through surgery for no reason. That will help push the tongue forward. What you really want to do is work with the company that brought the equipment out, work with a local sleep specialist, to find an interface, that mask that works well for you. That first mask that you get is not your only option, and patients aren't aware that they can switch that out. Give it a chance and really work to get accustomed to CPAP. CPAP is almost 100% effective.
Okay. And they hear a lot on the news about these new CPAP cleaners. Are they really something people should invest in, or what is your
Typically,
opinion on that?
you're fine with following the manufacturer's suggestions. A lot of times you want to avoid the water buildup. If you're cleaning your mask in a tubing, you want to make sure you're hanging the tubing so that the water gets out of there and it's not staying in the tube. You want it to dry properly. Usually that's enough. I don't know enough about those cleaning machines, other than they're expensive.
Yeah.
And they may not be needed. The manufacturer's suggestions are enough that should do it. If you feel like putting the money out to go through that cleaning process, you can give it a try.
Yeah, thank you. Well, I really appreciate this. This was great information. And the sleep information alone is worth watching it again, because all the things that you mentioned that will help us to heal, to fight disease, to improve our conditions just with getting sleep. You had some very good information about how to get ready for sleep that a lot of people don't seem to understand. And I thank you for your presentation.
Thank you for having me.